So over time, when we have more and more and more cortisol that gets produced, the body says, I'm not going to listen to that anymore. So that is what happens in the state of adrenal hyperactivity. What happens in the state of adrenal hypoactivity, where it's too low? When that is too low, what we have is a situation where there is no feedback to the hypothalamic pituitary axis. When that lack of feedback is happening, we see that the body keeps saying, okay, make more, make more, make more, make more. And in that low cortisol state, the person says, I need to find some way to get energy. So I'm going to eat sugar. We also see in that state there's more inflammation. And as I said a moment ago, the conversion of T4 to T3 becomes very active. This is when the cortisol is very low. So now we see a person who's very tired, who's not doing well, and we measure their T3 and it looks just fine. Or maybe it's even a little bit high. What we have to do is, instead of trying to give more T3 or T4, is we have to go back to understand what those lifestyle factors are that are at the bottom of our matrix model, of our map. We have to say, are you getting enough sleep? Are you getting the nutrients that you need? What is happening with stress and how you work with stress? So we focus on lifestyle and diet first. Then we determine, are there any nutrients that you need support with? Magnesium, riboflavin, vitamin A, vitamin E, selenium. Are there botanicals that can help bring you back into balance? But it's important to use botanicals that are trying to work to bring the body back into balance, not botanicals that are just trying to act like drugs to make the symptoms go away. And then, in certain situations, we may need to use hormones. So the dietary approach is one where first we focus on not too many sugars, an elimination diet, one that is rich in vegetables, fruits and vegetables. We want to avoid the caffeine and chocolate that act as stimulants. We find that when people move from the state of being aroused to beginning to move into adaptation and down into exhaustion, that it's at this point right here that the person decides, I'm going to eat a donut. I'm going to drink a latte. I'm going to try to add things that are going to keep me up because I don't want to feel exhausted. And so we use these, and yet all they are doing is moving us more quickly down that pathway because we don't have the nutrients that we need. Take fruits and vegetables to try to help us to get the kinds of B vitamins that we need. The vitamin C that's present in the fruits, the magnesium. But if we don't have these things in the diet, we can use them as nutritional supplements to support. Just quickly on vitamin C. Vitamin C is shown to improve adrenal function in marathon runners. Magnesium has been shown to be able to be very effective in stress, and when there is low magnesium, people have more of an exaggerated response to stresses that go on. So we find that magnesium and vitamin C and the B vitamins are important nutrients to help support that person who is having adrenal stress. Now, if we have someone whose cortisol levels are high, they're in that early phase, we can use those elimination diet, lots of fruits and vegetables, B vitamins, vitamin C, and magnesium. So we can use phosphatidylserine. Phosphatidylserine is a particular agent that at doses of 600 to 800 milligrams per day decreases excess cortisol. We can also use various herbs. The herbs that we can use, rhodiola, Russian golden root. Here we see at doses of 200 to 600 milligrams a day help us to decrease the arousal stage of cortisol. So in patients where we are looking at their cortisol levels, salivary cortisol levels, hyperadrenal, we can use rhodiola to help with that. We can also use hypericum, St. John's wort, particularly in your patients who may have a arousal that's going on of adrenal arousal, but also having symptoms of depression. St. John's wort is very useful there, helping to decrease the stimulation of the HPA axis. So in the patients, we're going to focus first on diet. Then we're going to look at the nutrients, B vitamins, vitamin C, magnesium, herbs like rhodiola and St. John's wort. And then we're going to say, what are the stressors that are going on? What are the antecedents, triggers, and mediators that are also going on that are causing problems for you? So we use the diet, phosphatidylserine, these pieces, and stress reduction. Now, stress reduction techniques, I was not able to put another slide in, but the stress reduction technique that I have worked with for the past 4 years now is one called heart rate variability biofeedback. There are several different tools that are available. Now one that is available connected to the smartphone. And it can be used as a way to help bring the person who is in this excess adrenal state, in this sympathetic drive, into parasympathetic balance. Heart rate variability biofeedback. And that can be used to bring balance back to the system. Now, how about in that person who is depleted? Not in the arousal state, but in the exhaustion state. There are other herbs that can be used. Panax ginseng helps to decrease the anxiety that's present. And in doses here of 100 to 200 milligrams 2 times a day, we've found that it helps to increase the cortisol response. These are people whose cortisol response is very, very, very low. So when we used herbs with this group of people, we found their cortisol levels went up. Now, I'm going to speak of this herb of licorice, but I'm also going to tell you why I don't like to use it. Many people use it in this state because what we see is there's a conversion of cortisol, which is the active form, to cortisone. Cortisone is inactive. Licorice, Glycyrrhiza glabra, will stimulate the conversion of the inactive cortisone into cortisol. Actually, it blocks the conversion of cortisol to cortisone. So in that way, it's artificially acting right in this state. We give licorice, and so instead of cortisol converting, turning off to cortisone, it stops, it blocks that pathway right there. So artificially, we're going to see cortisol levels coming up. But for me, This is a form of green pharmacy. It's just using an herb to act like a drug. It does not help to bring the system back into balance. Panax does, rhodiola does not. But I want to make you aware of it because many people will say when I have someone who has adrenal problems or adrenal exhaustion or low cortisol, I will give licorice, glycyrrhiza. I do not recommend it. It will make the cortisol levels go up, but it is temporary. And some people may actually need DHEA. DHEA can be useful as a bridge, as a short-term bridge, to be able to help these individuals. DHEA out here, as a hormone, we see that when there's this cortisol steal effect that's going on, there's a blockage, and there's not adequate amounts of DHEA produced. By giving DHEA, we help with anabolic hormones in the short term. But ultimately, we have to reverse the cortisol steal. Because if we just think that we can keep giving people DHEA and DHEA for the rest of their lives, the studies actually show that there is not a long-term benefit to giving DHEA. There is a short-term benefit to give DHEA. And when we understand, the reason I share with you the biochemistry here is to understand why that's true. It also helps me to recognize that when I'm bringing the body back into balance, that is the most important thing, rather than trying to just give a drug like DHEA to bring it back into balance. Working with the diet and the stressors, nutritional supplements, and the antecedents, triggers, and mediators is what has to be done. If you use DHEA on a short-term basis, the doses on females are lower than the doses on males. And when you give DHEA, because it is anabolic, like testosterone, you have to watch for symptoms where you may see hair growth occurring, acne, other signs of excess androgens that are present. So we look out for these side effects of acne and facial hair. Men will tend to have more symptoms of being aggressive or irritable if they're excessive. So when they're in this state of adrenal exhaustion, we again are going to say, what are the stressors and what are the traumas? What are the antecedents, triggers, and mediators that are causing this state to occur? There's an important point I want to make clinically here of why I feel that understanding where the person is, whether in cortisol excess or cortisol deficiency, whether in arousal or exhaustion, is that the patients who are at this point of low cortisol require a lot more time and effort to bring them back into balance. Your interventions, your coaching, your support with them in terms of diet and nutrition will take more time, and your expectations with them that you have with them are that this is going to take a while to help bring you back. You didn't get to this point of exhaustion, of low cortisol in 3 weeks or 3 months or 3 years. This is a long-term problem, and it's going to take a while. And as long as you help them to understand that, so that you're working slowly with them to find out, well, what are the antecedents, triggers, and mediators? What are the stresses? What are the thoughts and beliefs and memories and feelings that are ongoing creating stressors to be able to help them? So the stress reduction techniques, like heart rate variability biofeedback. Some people will do well with trauma techniques. We don't go into those a lot here, but there are eye movement desensitization techniques that can be worked with to deal with trauma if they have memories of trauma that keep coming back. Dietary changes, as I talked about, using Panax, not so much licorice, and DHEA if necessary. I very, very rarely use cortisol, whether compounded or in a formula, a porcine or bovine, a pig or a cow adrenal formula with their adrenal hormones. Very rarely use that kind of cortisol because it is just a substitute, and we need to work with getting them back into balance. One of the things that helps, not only heart rate variability biofeedback as a stress reduction tool, but we even have more recent examples of mindfulness-based stress reduction. This is a form of meditation which can be used, which has been demonstrated that it can help to normalize cortisol levels and normalize DHEA levels. So when we're going through the process, what we want to do is we want to begin to understand the patterns. The pattern within the adrenal glands of, are they normal? Are they aroused? Are they adapting? Or are they exhausted? We want to evaluate the antecedents, triggers, and mediators. Recall that we talked about those earlier, that they're going to relate to stress and trauma and infection and inflammation and dietary issues. So this is the way in which we work to try to bring balance back to the system overall. Let's talk a little bit more about what's happening on the side of the thyroid. I've spent most of the time talking about the adrenal glands so far. So let's talk about the hypothalamic pituitary thyroid axis. We've seen how stress can have an effect on the thyroid. We've seen how stress and high cortisol levels can have an effect on changing the conversion of T4 to T3. Well, let's look at the overall effect of the thyroid, which produces T4 in the kidney and the liver, and that goes down, T4 in the thyroid gland, and that goes down into the kidney and the liver. And what kinds of things will have an effect on that? So recall the idea of PTSD, production. Factors that are going to contribute to the normal production, I've mentioned. Tyrosine is the amino acid that's necessary for the production of thyroxine. We also need to have iodines. People who are iodine deficient in their diets will have a difficult time being able to make T4. We also need zinc, vitamin E, riboflavin, pyridoxine, vitamin C, and a proper balance of antioxidants, plant-based antioxidants. These are all necessary for the production of T4. Now, what things are going to inhibit production of T4? I've mentioned a few of them so far. Autoimmune disease like celiac disease, and in fact, we see this with Hashimoto's thyroiditis as well. Gluten and wheat may have some relationship to the decreased production of thyroid hormone, of T4. We also see that various toxins, like fluoride. Fluoride binds to the thyroxine to the thyroxine molecule, to tyrosine, rather than iodine. So when there's high amounts of fluoride that are present, that can actually get in the way of making thyroxine. The tyrosine molecule binds fluoride instead of iodine. Stressors in and of themselves, because recall that high cortisol level will decrease TSH stimulation of the thyroid gland. So high stress and high cortisol level in that activation or arousal state will actually decrease the production of thyroid hormone. And then we see that there are various medications that will decrease thyroid hormone production from going on. Pesticides and toxins including mercury, cadmium, and lead. All of those will decrease the production of T4 hormone. So what about the conversion? We spent a little time, you saw those diagrams, and you can see that selenium and zinc are necessary. Selenium, the enzyme that converts T4 to T3, is called a 5' deiodinase. That means it removes the iodine. And that is a selenium-dependent enzyme. If you have a deficiency of selenium, you won't be able to convert that. So there's an important note here that relates back to also the production of T4, and that is that there is a very important heavy metal toxin that competes with selenium, and that's mercury. So if you have high levels of mercury, it will actually inhibit this enzyme from working properly. So selenium and zinc are necessary to help that, but we can see that selenium deficiency or the presence of mercury, as well as cadmium and lead, all will decrease the conversion of T4 to T3. If we have inflammation that's going on with cytokine production, it will decrease the conversion of T4 to T3. Interestingly enough, excess amounts of estrogen will lead to decreased conversion, and we already talked about the stress effects of high cortisol decreasing T4 to T3. Now, I would say it was probably 12, 14 years ago that I learned of these interactions, and it continues to boggle my mind why we would want to give T4 as the treatment of choice for someone who's got low T3 levels. Because we have to make sure that they have everything else in balance. Because all these things are going to decrease the ability of the body to convert and utilize that T4 that's being given as a drug. So we see here factors that convert, decrease the conversion: starvation, low-calorie diet, inflammation, infections, stress, trauma. All those things are going to decrease the conversion of T4 to T3 and increase the conversion to reverse T3. Some interesting data from a few clinical studies in the United States that also depression seems to be related to an increase in the production of reverse T3. Now, there are functional medicine laboratories that can measure not only T3 but reverse T3. So we talked about production, we talked about transport and movement, we talked about, now let's talk about the sensitivity. When thyroid T3 binds to the thyroid receptor at the cellular level, it requires vitamin A, vitamin D, vitamin E, and zinc in proper levels in order to be able to work effectively. So we have this particular chart in your toolkit to remind you, to help you, how do I put all of these pieces of the puzzle together. We have a questionnaire that helps us to understand thyroid imbalance. When we think about thyroid imbalance, remember that Dr. Hughes talked about on the first day of how we had been to the Forbidden City and the Imperial Palace, and our guide had a decrease in the eyebrows on the lateral third, an indication of hypothyroidism. We can also see hair loss, edema, slow tendon reflexes, an enlarged thyroid gland, concentration problems. So there are a number of different things to consider. Is there a thyroid imbalance that's going on with this individual? And as I've said already, if there's a thyroid imbalance that's going on, you measure TSH, T4, T3, reverse T3, measure that in the serum. That's the best place to be able to do that. If you see that, not only do you want to work with that and those possible nutritional issues, but you want to see, is there any stressor that's going on where their cortisol is high or very low that is getting in the way. You want to look at their adrenal glands also. Now, we saw earlier that when adrenal activity and cortisol is high, it blocks the conversion of T4 to T3. And we found that when cortisol level is low, it actually elevates T3. We can also see that when people are in sympathetic overdrive, when they have a lot of adrenaline that's going on, that actually will decrease their ability to produce T4 in the first place, which is why we want to continue to say, focus on the adrenals. Now, when we're talking about sex hormones, when Dr. Hayes talks about sex hormones on Wednesday, I already showed with you that if you have high cortisol production, you're going to decrease your production of anabolic hormones and decrease your production of estrogens. I've shown you about the relationship between cortisol and thyroid hormone, that when cortisol levels are high, they block the conversion of T4 to T3, and when cortisol levels are low, they stimulate the conversion of T4 to T3. Now, this slide actually talks about, well, what happens in the setting? What is the relationship between thyroid hormone and sex hormones? And primarily, that's mediated through sex hormone binding globulin. This is the hormone, or this is the protein that carries around testosterone and estradiol. And when we see someone who is hypothyroid, has low T3 levels, recall that they could have low T3 levels because they don't have adequate selenium, they've got mercury present, they've got stressors that are going on, number of different reasons that can happen. But when their thyroid is low, when they're hypothyroid, it actually decreases the circulation of the protein, sex hormone binding globulin. And when that is decreased, all of a sudden you have an increase in your free amounts of estradiol and testosterone. So this part, I'm not so much wanting you to understand all of these interrelationships right now. You'll have this here to go back to. My key point here is to help you to see that there is an interrelationship between the adrenals and thyroid, adrenals and sex hormones, thyroid and sex hormones. They are interrelated with each other. And when we see imbalances in any of them, we want to come back and address what's happening with the adrenal glands first. So when we see someone who's got thyroid imbalance, I'm asking you to consider what's happening with their adrenal glands. So that means in your patients who have a low TSH, a low T3 or a high TSH, commonly seen. In the United States, we have maybe 10% of our patients who have this kind of configuration of high TSH above 2.5 and normal or low T3. And in those patients, before I go to start giving them thyroid hormone, I work on their diet, I make sure their nutrients are okay, and I look at the diurnal variation of cortisol to see are they in a hypercortisol or a hypocortisol state. And this is what I mean when I talk about the pattern recognition that's happening here. So how do you treat this? Well, nutritionally, we want to make sure that they're able to produce T4 and then convert that T4 to T3. So recall that nutritionally, we said the things that are necessary are going to be zinc, iodine, tyrosine, B2, and B6 in the production. In the conversion of T4 to T3, we want to make sure that they have normal levels of cortisol, adequate levels of selenium, and no presence of toxins like mercury and cadmium and lead. Also, with anyone who's got thyroid issues going on, we want to make sure that they do not have celiac disease, and we want to make sure that they do not have Hashimoto's thyroiditis. Whenever I'm evaluating someone initially with fatigue, I'm not only looking at TSH and T4 and T3 and reverse T3, I'm also measuring autoantibodies to anti-TPO and anti-thyroglobulin. So as we see, when we're looking at the overall picture of both thyroid and of adrenal, we can see that first we want to look at where is it produced. If I have excess amounts of cortisol that are being produced, as I see in the diurnal variation of cortisol, then I need to deal with what are the stressors that are going on that are causing that. If I have decreases in the cortisol that's being produced and they're in an exhaustion phase, I need to understand what are the stressors and how to support the adrenal glands. If I see excesses in the production of thyroid hormone, as I would see with Graves' disease, then I would want to understand, is there some autoimmune process that's causing that? But more likely, do I see a decrease in the production, and I'm going to look at those nutritional factors. What's happening with transport and conversion? Again, we've talked about this with both adrenal hormones, with cortisol and DHA, and with thyroid. We use this graphic on the thyroid to talk about production, conversion or transportation, and sensitization to see what are the elements that we want to consider PTSD to bring balance back to the system. And then finally, do I need hormones? There are some patients who we do this with, and we actually do need to give them hormone replacement therapy. Levothyroxine, that's T4. If I'm giving someone T4, I want to make sure that they're able to convert it to T3 properly. I want to make sure that they have adequate nutrients. We also have in the United States the ability to use various kinds of animal thyroid, and those animal thyroid products will have a combination of T4 and T3 in them, which I prefer to use because I'm giving the active T3 as well. I'm not only counting on the body's ability to convert T4. So these are pharmaceuticals. This is often it can be as a supplement, or maybe a pharmaceutical in China as well. This is my preferred mechanism we also have pharmacies in the United States who are able to mix together T4 and T3, compounded formulations, to be able to treat. So what I've focused on is the communication within this functional medicine matrix. Now, I've just gone into highlighting the adrenals and the thyroid aspect. We're going to have lectures all Wednesday morning by Dr. Hayes that will go over in detail how that relates to sex hormones. And so we'll go into this in much more detail. But as I said, whether there's a sex hormone imbalance or a thyroid hormone imbalance or an adrenal imbalance, you want to treat the adrenal glands first. It's a very, very important principle. And if out of all the things that I said today, you don't remember anything except that, you will be farther along than I was 15 years ago when I began to use these tools, because I didn't understand that at that time. And I would chase myself around trying to find the answer by giving hormones when that wasn't the right thing to do. So I appreciate you all for listening, for being attentive on this afternoon. We're going to have a break for about 15 minutes, and then Dr. Hayes is going to come back, and she is going to be introduced, I think, for the first time. And she is going to go over a case study that is going to help you to understand how you apply these tools in practice. Thank you very much.